I'll now introduce our next speaker. Dr. Brendan Everett is going to talk to us about valvular heart disease. Dr. Everett is an associate professor of medicine at HMS and directs the cardiovascular inpatient service at Brigham and Women's Hospital, and has perennially done an amazing job with this complex topic. So I'll hand it over to Brendan. Thanks very much.
Thanks, Akshay. I hope everybody can hear me. And assuming that you can, we'll charge ahead. So valvular heart disease, this is a complex subject with not only just a number of different valves, but a number of different pathologies. And we don't have a lot of time to cover it today. But everybody's being, I think has modified their lectures to deal with the new online format. So I'll try and go through it and leave some time for questions at the end. The first lesion, as you might imagine, is aortic stenosis, this being one of the most common that we would typically see in clinic, one of the most important. And this, of course, is the classic figure that I'm sure you've all seen and remember, whether it was in medical school or more recently from Dr. Braunwald, which shows that the aortic stenosis can progress for a long period of time without causing symptoms. But once the patient has severe symptoms, their decline towards death is relatively rapid. And the different kinds of symptoms that we typically think of are heart failure, syncope, and angina, with each one being of different severity in terms of predicting prognosis. And I think one thing that's interesting to me in this figure is that, of course, it looks like most of the individuals with aortic stenosis are presenting and dying by the time they're about 65 here, maybe even less than that. That's not my clinical experience. I don't know if that's yours, but I think over the years since this seminal work was published in 1968, there's been a change in when we see aortic stenosis and what we can do for it, which of course is one of the reasons why it's so exciting to talk about it. So these are the key things to remember, and I think it's worth saying that the numbers in the right-hand column here for severe aortic stenosis are ones that are burned in my brain, and I think for many people who see patients with aortic valve disease, these are the key metrics that you need to think about when you look at an echo for somebody who has a murmur that you've ordered to evaluate a murmur that was consistent with aortic stenosis. So severe aortic stenosis has a jet velocity of 4 meters per second, or a mean gradient of 40 millimeters per mercury, or a calculated aortic valve area of less than or equal to 1 centimeter squared. Now, sometimes you can further divide that valve area by the patient's body surface area to get a valve area index. The idea being that maybe a small patient does not need as big a valve as somebody who's 6'4" and 250 pounds, but typically these first three numbers are really the key ones. And so these are the criteria for when you think about replacing a stenotic aortic valve. The most important thing to remember, of course, is symptoms. And I want to underscore that because it really takes a careful history and it takes some time. And you sometimes have to explain to the patient what they should be looking for. And, sometimes they might have to come back and tell you, I used to be able to go up these flights of stairs with the laundry basket in my hand, and now I can't anymore. And they may not have noticed because they've just adjusted their behavior quietly in the background, not consciously, subconsciously. And then before they know it, they've restricted their activity so they don't feel like they're short of breath. But if you actually ask them to make a careful comparison, they'll notice the differences. If they need bypass surgery or aortic surgery for another indication, that would be a class 1 indication for having the aortic valve replaced. And if the ejection fraction has dropped to less than 50% as a result of the aortic valve stenosis, then that's another reason to think about replacement. There are other class 2A and class 2B indications here further down in the table. So in general, we don't recommend that you do an exercise tolerance test in somebody with aortic stenosis. It's just probably not the best. It can be dangerous, first of all. If you are working with a cardiologist and trying to time surgery and think about whether or not a patient who doesn't have symptoms might actually have important hemodynamically important aortic stenosis, you can do an exercise tolerance test. And what you're really looking for is a blunting in the blood pressure response. And I guarantee you that if you're going to do this, you want to talk with the person who's going to be putting the patient on the treadmill and watching them while they're exercising. If you think their aortic stenosis is going to progress rapidly, and clinically where I've seen this is when somebody who has moderate to severe aortic stenosis goes on dialysis or develops worsening kidney failure, all of a sudden the calcium balance and metabolism shifts dramatically, and they can end up getting an accelerated aortic stenosis that you need to anticipate so that it's not too late. And then very severe aortic stenosis, very, very small valve areas, independent of the actual symptom status of the patient. So when you have severe AS, I think it's helpful to divide it up into two categories in your mind. And when you're seeing somebody who has a valve area less than 1 centimeter, or if they meet some of the other criteria I discussed. And you'll see why I think it's helpful to divide it up this way in a moment. So first is the classic high gradient AS. This is what we see. This is most of what we see, somebody with a valve area it's calculated at less than 1. Their ejection fraction is good. It's in the 60% range, let's say. Their gradients are high, so their mean gradient is more than 40 millimeters of mercury. Their peak velocity is 4 meters per second. This is a straightforward patient who needs an aortic valve replacement, assuming they're symptomatic. Low gradient AS is much more challenging. And in the past, here you have, a small aortic valve. And in the past, we sort of thought of this as people with a depressed ejection fraction, an EF of 25%. Their valve is narrow, and the clinical question became, is the EF low because of the AS? In other words, does the valve stenosis cause the patient to develop a non-ischemic cardiomyopathy, a weakening of their heart muscle? Or is the aortic valve area small because they have a cardiomyopathy? And if we fix the cardiomyopathy, the heart would actually be able to open the valve better. And so they'd have better flow. And that's an important clinical question. I'll show you how we typically approach that in a moment. More recently, there's this category of preserved ejection fraction, low gradient AS. And this is as much as 25% of AS patients. So it's increasingly common. And here you have a valve area that's small, but the gradients are not high. So it can be difficult it can be easy to ignore it as not being important. Plus the patient's ejection fraction is preserved. So you just assume that their gradients should be high. They should have a mean gradient of greater than 40 millimeters of mercury. So I'll go through how this can happen in a moment. So this is a schematic that can perhaps help you to begin to understand it. So first of all, on the left, you have a normal ejection fraction with normal flow, high gradient. Garden variety AS, what we see all the time, right? You can see here that the heart is able to expand in diastole to accept blood well. It has a good ejection fraction. And so, but there's a stenotic valve here. It's almost like the low flow types of AS are sort of two different flavors of the same thing. We all know that we have patients who have preserved ejection fractions who actually don't have a good cardiac performance. They don't have good flow. They have heart failure. They have exercise intolerance. They have shortness of breath. That's the patient here on the left-hand part of this, or the middle of the figure overall, I guess. These are patients who might have a low flow, low gradient AS, even though their ejection fraction is 60, 70, maybe higher. Here's the classical low flow, low gradient AS. These are the people I mentioned initially, right? With the cardiomyopathy, the dilated ejection and low ejection fraction, they're not able to generate a high pressure gradient across the valve because their heart muscle is sick. Okay, so when you have a patient in this low flow category who has what you think is severe aortic stenosis and they have a low ejection fraction, the first thing to do is to call the echo up on your screen or ask the cardiologist who read it, was the valve calcified? If the valve isn't calcified, it might not be AS. On the other hand, if the valve is very calcific, just really thick calcified valve, then you probably almost certainly have AS. The next test for these patients would be a dobutamine stress echo. And I'm sure you remember this from your internal medicine training. Basically, what you're trying to do is to give the ventricle a boost and try and help it generate more cardiac output. So if you're able to generate more cardiac output and the gradient goes up, but the valve area basically doesn't change, what you've demonstrated is that it's the valve, it's not the heart muscle. The gradient goes up as the flow goes up. And here, this patient is most clearly the one who's going to benefit from some kind of aortic valve replacement. If the gradient goes up, the cardiac output goes up, the gradient goes up, and the aortic valve area also goes up, then that typically means that this person has a cardiomyopathy of some sort, could be ischemic, could be non-ischemic, that's preventing them from their heart from generating the force it needs to generate to open that valve adequately. This would be somebody who would be a candidate for medical therapy. On the other side of this is somebody who has maybe a little bit of some increases in cardiac output, maybe not that much. The gradient doesn't really change that much. The valve area doesn't really change. This is a group of patients where it's difficult to know what to do. It's not unreasonable to consider an aortic valve replacement if you think they're not otherwise too high risk. It's also reasonable to consider medical therapy. These patients, as you might guess, don't tend to do that well. Okay, so these are the guideline recommendations. Basically, an AVR is reasonable in symptomatic patients with low flow, low gradient, severe AS with reduced ejection fraction, exactly the people I was just talking about on the last slide, where you can generate an increase both in the cardiac output and the aortic velocity with dobutamine, okay? That's a class 2A indication. And then you have this other class of patients where an AVR is reasonable in symptomatic patients with low flow, low gradient, severe AS, who are normotensive and have an EF greater than 50%. So this is the paradoxical, or it's the low flow, low gradient AS with preserved ejection fraction. We don't really know how these patients do. We don't think they do as well as the classical patients who have preserved ejection fraction and high gradients, but there's people where you might consider replacing the valve. Okay, this is the current guideline that, for choosing between TAVR or SAVR. And this generally is something that the cardiologist and the heart team will do in conjunction with the surgeons. But you can, if you're an internal medicine practitioner and you're trying to give your patient a sense of what to think about, in most cases, we consider TAVR. So on the right here, you have people who have prohibitive surgical risk. These are patients that we would not have operated on before, and they would have had very high mortality. These patients can be offered a TAVR, provided that technically it's feasible to do so. If patients have high surgical risk, and this typically means a 15 to 50% 30-day mortality. So sick patients who are unlikely to do well with surgical AVR, we increasingly, I think, tend to hedge towards TAVR in this group of patients if it's, again, technically feasible. The intermediate surgical risk are probably the group of patients where there's the most, you could go either way. These are patients who have a 3 to less than 15% 30-day mortality. This is not the well patient necessarily. They may have some other comorbidities, but nonetheless, you can consider both open or classical surgical aortic valve replacement and transcatheter. In this group, low surgical risk, there are ongoing trials as we speak. So this is an open question. And not only that are they low surgical risk, but some of them may even be potentially asymptomatic or close to asymptomatic. So this is another frontier in aortic valve replacement in this clinical space where we don't quite know what to do. And there's the potential that treating these patients, not just with TAVR, but potentially with TAVR prior to the onset of really bad symptoms, we may offer those patients some benefit. Okay, aortic regurgitation, less common, but also important to know about. You can see here the different causes of aortic regurgitation. Typically, the one I see the most of is bicuspid aortic valve disease, which often is associated with a dilatation of the aortic root. You can see aortic regurgitation when there's been a dissection. Obviously, infective endocarditis, increasingly a problem that we've seen a lot here in Massachusetts, at least. And then there are other less common etiologies: antiphospholipid antibody syndrome, fen-phen, a blast from the past there, myxomatous degeneration. Hypertension is probably underrepresented as an important cause of aortic dilatation and subsequent aortic regurgitation. Unlike the numbers that I gave you for aortic stenosis, I think these for regurgitation are just much more difficult to remember. And in general, regurgitant valve lesions are harder to classify in terms of their severity. Here are the numbers. A vena contracta is, what's essentially the area that the jet is going through, the regurgitant volume, the regurgitant fraction. These are the numbers that you should just have somewhere to refer to should you have a patient with what you think is severe aortic regurgitation. Unfortunately, medical therapy has not really worked to prevent the progression of aortic regurgitation to requiring surgery. Here's a randomized trial published now 15 years ago in the New England Journal of Medicine comparing enalapril, nifedipine, and control. You can see that there was no difference between the three groups in terms of preventing time or slowing the time to aortic valve replacement. Generally, we think about surgery when the patient has symptoms or when their ejection fraction has dropped to 50%, or if they need surgery for something else, for example, their ascending aortic aneurysm. The class 2 indications, again, are looking carefully at the numbers and the dimensions of the heart. If the end systolic dimension appears to be increasing up to 50 millimeters, that's pretty big, honestly. And the end diastolic dimension is 65 millimeters. Both of those numbers are pretty large. If they're not quite there yet, but they're increasing progressively, then you might think about operating as well. So regurgitant lesions are something that require kind of every, depending upon the severity, 6 to 12 months, repeat echoes for evaluation, mostly of these parameters, because you don't want to miss a cardiomyopathy induced by your aortic regurgitation and miss the opportunity to operate and correct the lesion. I put this slide up because this is a section of somebody's chest. The head is up here, the feet are down here. This is the aorta, and this is the kind of aortic dilatation you can see with bicuspid aortic valves. It's very common if you see somebody with a bicuspid aortic valve to look for ascending aortic aneurysm. Sometimes it's not well evaluated on a transthoracic echo. Typically, I would recommend a CT angio of the chest to ascertain really what the dimensions of the ascending aorta are. And then you want to track those if it is dilated, because that, of course, can be an indication to move to surgery too, in addition to aortic regurgitation. So I've listed the indications for surgery here when somebody has both the bicuspid aortic valve and a dilated aortic root. And again, you think this is unusual, but this is the most common cause. This complex that you see right here is what I mostly see for ascending aortic aneurysm. We typically operate when the maximal dimension of the aorta is 5.5 centimeters. Or we can repair that aorta when we have to operate for the AS or the AR that might be coincident with the dilatation, and then we'll potentially repair the aortic root at that time too. Also, if the dimension is 5 centimeters but appears to be increasing, or there are other important risk factors like a family history of sudden death from aortic dissection, you may want to operate a little bit earlier than you otherwise would. Okay, so let's talk about mitral regurgitation, another valve lesion where there's been a lot of innovation over the past few years. And, mitral regurgitation is divided up into acute and chronic. Acute mitral regurgitation would be typically seen now most commonly, frankly, in endocarditis, at least at the Brigham, but also occasionally in acute MI. And now that we're typically intervening quickly on most myocardial infarctions, you see it a little bit less. It's a posterolateral or infraposterior MI that would affect the papillary muscle, cause it to necrose and then rupture, and then you would have full open MR. Chronic MR can be from myxomatous degeneration typically, but also can be from ischemic heart disease that causes dilatation and malcoaptation of the leaflets. Same with dilated cardiomyopathy. Okay, so when patients have symptoms and the valve appears to be severely regurgitant, that's when you start thinking about operating. And you'd be surprised how many patients with moderate to severe or severe MR, frankly, have no symptoms. So you have to be careful here and watch them and ask your probing questions and your history about, are you truly asymptomatic? And you also have to look at their LV dimensions here over time, because what happens is eventually through the Frank Starling method, the heart dilates to accommodate the extra volume because of all the regurgitant blood flow back towards the atrium. But ultimately, it can actually dilate so far that the ejection fraction kind of falls off a cliff and goes from being supernormal, 65%, to 30%. And then you may have increased the risk for your patient to have a surgery. So again, every 9 to 12 months where you just are sort of doing an echocardiogram just to evaluate this. And typically these patients will be followed by a cardiologist who will take charge of those sorts of things, but maybe not. And you might be the person who has to keep track of that. Chronic mitral regurgitation is, if the patient typically does not need antibiotic prophylaxis, if they've not had prior endocarditis, if they have had endocarditis as the reason for the MR, then they would, obviously. But if they have just myxomatous mitral regurgitation, then typically that's not anymore an indication for antibiotic prophylaxis for dental work. There's often atrial fibrillation. Some people consider that an indication to move to surgery. And if it's truly valvular atrial fibrillation, then you're probably pushed a little bit towards warfarin as your anticoagulant agent, as opposed to some of the newer anticoagulants, although as the trials went on in that space, they became more inclusive of patients with some valvular heart disease. You have to manage the coronary disease, of course, if that's the etiology of the chronic MR. Generally speaking, if somebody doesn't have hypertension, there's really no role for vasodilator therapy in mitral regurgitation. However, most patients do have some degree of hypertension, so then an ARB or an ACE inhibitor is a reasonable first choice for that blood pressure. These are the indications for surgery in asymptomatic severe primary MR. If the ejection fraction has dropped, as I said, and the LV systolic dimension has increased, these are the ESC guidelines and these are the AHA. They're pretty similar. Basically, EF between 30 and 60 or an expanded systolic dimension. That's the class 1 indication. These are all class 2A. So if you have atrial fibrillation or new pulmonary hypertension, if you have a preserved ejection fraction and you think you'll get a good repair, you have a flail leaflet and the end systolic dimension looks like it's starting to get a little bit bigger. I think the key feature here is that you have to be confident that your surgeons will be able to do a repair rather than a replacement of that valve. A replacement typically would mean some kind of anticoagulation, right? And if you want to avoid that, if you can, in somebody who's otherwise feeling well. And then there are some other indications here that are even softer, just for example, an ejection fraction less than 30, and here pulmonary hypertension, particularly with exercise. So you could do a stress echo where you look at the PA pressures with exercise, and if those go up, then you might think about operating. But again, it may make sense to wait until the patient develops some exertional intolerance, some dyspnea on exertion, before you can be confident that you're going to make them feel better by sending them to the operating room rather than just worse. Okay, so prosthetic valves are an important part of what we do. Now, here's a tissue valve on the left, and here's a mechanical valve on the right. There are a number of complications you should just keep in the back of your mind if your patient has had an aortic valve replacement, or most typically, but also a mitral valve replacement. They can have structural valve deterioration. There can be leaks around the valve. There can be hemolytic anemia. That tends to be a little bit more common with the mechanical valves. They're at risk for infective endocarditis and thrombosis, particularly if it's a mechanical valve and they stop taking their anticoagulation for some reason or another. Pannus is basically scar tissue that kind of forms in the annulus and sort of comes over the top of the valve to make it narrower and give it difficulty with opening and closing. And then the classic is prosthesis patient mismatch, where the patient is big and the prosthesis is small, and as a result, they have gradients even after having the operation. This is something that wasn't really clear to me until I became a cardiologist, that there are some indications, class 1 indications, for antithrombotic or antiplatelet therapy in patients who have had aortic valve and mitral valve replacements. So if you get a mechanical valve, typically you should be on aspirin regardless. If you've had an aortic valve replacement, you should be on warfarin with a goal INR of 2 to 3. If you have an aortic valve replacement with a mechanical valve and you're high risk, and the risk factors are here, okay? AF, previous thromboembolism, LV dysfunction, hypercoagulable condition, an older generation mechanical AVR, then you have to think about a slightly higher range for your INR. Notice I'm not saying any of the DOACs here. This is warfarin, right? And then an MVR, you always have to have this range of an INR of 2.5 to 3.5 with warfarin. Anybody with high-risk features really requires a bridge. So if you have somebody who has a mitral valve replacement, who's on warfarin, and they need an elective surgery of some sort, let's say it's a knee replacement, that requires a bridge, unfortunately, particularly if they have high-risk features like atrial fibrillation or a prior thromboembolic event. Those patients really should be brought into the hospital as the warfarin is coming off and put on unfractionated heparin or a low molecular weight heparin so that they can then transition to the operating room easily and safely. This is the guidelines for antithrombotic therapy with a biological valve. Again, here you have aspirin as a class 2A. That's not terribly strong, but it does suggest that even in your patients who wouldn't otherwise be on any anticoagulation, that you might consider a low-dose aspirin. Oftentimes we'll treat TAVRs with a combination of dual antiplatelet therapy for the first 6 months and then just aspirin after that. Mitral valve surgery often in the past was treated with 3 months of anticoagulation. I think there's less, the practice varies widely in this case. That's what I'll say. So what do we do about endocarditis prophylaxis? And this is an important issue, I think, and it sort of falls in valvular heart disease because that's where we think about it. So I think if the patient has already had some kind of valve replacement and has prosthetic material there, generally, including TAVR, generally we would recommend that you treat them with prophylactic antibiotics prior to a dental procedure. If they've had endocarditis in the past, certainly treat them with prophylaxis. If they have cyanotic congenital heart disease, so some kind of shunt that leaves them a little bit blue that's unrepaired, that's an indication as well. If they've had that repaired, they have congenital heart disease and they used to have a shunt and it's been repaired with prosthetic material, but it's early after that repair, so the first 6 months, that's another reason to use prophylaxis. If they've had congenital heart disease with a repair, but sometimes the repairs still leave shunts, and you'll hear from Anne-Marie later today about congenital heart disease, that's another indication because there you think of it as being like turbulent flow near a prosthetic surface that could be potentially a victim of infection. And then, of course, cardiac transplantation. Many of these patients have some degree of valvular dysfunction and they're typically immunosuppressed. Here are some antibiotic regimens. I don't need to read through them. I'm sure they're familiar to you, particularly the amoxicillin, but there are some suggestions for alternatives if patients are allergic or if they have to have just intravenous forms. So We have quite a bit of time, actually, but we'll go through these questions slowly, and I think we can, I'll explain them as we go. So here we have a 70-year-old woman who has worsening dyspnea on exertion. She has a history of mild renal insufficiency and also has some, let's say, mild COPD. When you examine her, her heart rate is 72. Her blood pressure is a little bit elevated at 156/80. And she has a grade 3 out of 6 late peaking murmur of aortic stenosis. Her ECG shows normal sinus rhythm, but some left ventricular hypertrophy. And the echo that you order shows that she has a calcified aortic valve with a mean gradient of 50, an aortic valve area of 0.8 centimeters squared, and her wall thickness, her LVH, is 15 millimeters or 1.5 centimeters. Her ejection fraction is 75%. So of these options, therapeutic options given to you, which is the best response? So you could give her a diuretic and an ACE inhibitor with close follow-up. You could use a surgical bioprosthetic aortic valve replacement. You could do a mechanical aortic valve replacement. She's 70 years old, remember? And you could give her a transcatheter aortic valve. So those are your options. I'm going to wait for a few more of you to, out of 340 people, can we get 75, 50 to 75 to vote? Oh, you can change too. All right, we'll stop at 100. So I understand I have to, so the correct answer here is transcatheter aortic valve. This woman is 70, and we'll go over these answers in a moment. I think that surgical bioprosthetic valve is probably the next most reasonable option because 70 generally puts you in the category of a bioprosthetic valve as opposed to a mechanical valve, which is why C is probably not the right answer. And if she is not, if technically a transcatheter valve isn't feasible, then you would think about a bioprosthetic valve. A diuretic and an ACE inhibitor would probably not be a reasonable way to proceed. And that's largely because diuretics in patients with symptomatic aortic stenosis, they're preload dependent. And so if you drop their filling pressures too far, you can actually make them feel worse. And if you detected a little bit of heart failure on exam, I think a low dose of Lasix might be reasonable, but probably the best thing to do given her complex of symptoms and exam findings in the echo is to send her to what we call the heart team to have a look at her valve and decide whether or not a surgical versus a transcatheter replacement made the most sense. The COPD was kind of in there to push you in the direction of a transcatheter valve because, of course, the pulmonary complications of a transcatheter approach are less than a surgical approach. Okay, question 2. So you have a 71-year-old woman with a St. Jude MVR. So she's had a mitral valve replacement, right? And that's a mechanical valve. She's scheduled for laparoscopic cholecystectomy. She had a TIA 2 years ago, and she takes warfarin, low-dose aspirin, metoprolol, and furosemide. Her labs include an INR of 3.4, a serum creatinine of 2, which gives you a creatinine clearance of 27 mLs per minute. Which of the following strategies would you recommend for anticoagulation management in this patient? So you could tell the surgeons to just stop the warfarin and operate when her INR gets to 2. You could just hold the warfarin and operate at that point, whenever that is. You could hold the warfarin, admit for intravenous unfractionated heparin when her INR drops below 2.5, and then operate after that. You could hold the warfarin, bridge with enoxaparin, 1 mg per kg BID. So it's a two-way race here, it looks like. Nobody is fooled by my options A and B, and that's good. You don't really And this patient who is high risk, remember she's had TIAs before, she's on anticoagulation with an INR goal of 2.5 to 3.5, which is appropriate given her valve. You don't want to just, first of all, you don't want her INR really down to 2. That's one reason why A isn't really correct. And B just kind of scares me because you're going to stop the warfarin and who knows what it'll be and then come in and operate. I think option D would be reasonable if she didn't have some amount of kidney dysfunction. And so I have in the past treated patients like this of my own with enoxaparin, but they have to have reasonable kidney function. Of course, they also have to be able to administer the shots. And then they can give themselves a shot the night before and then come in for the operating room the next morning. Sometimes it helps to talk with the surgeon. They might want you to hold that very last dose of enoxaparin. But probably the right answer here is C. You can stop a couple doses of the warfarin, admit her to the hospital, check her INR, and when it's less than 2.5, then you start on fractionated heparin, and then she goes to the operating room when the INR is in a range that the surgeon is comfortable with. And I think, Akshay, that is it. Yeah.
Yeah.
So these are specific indications that we discussed on that in that last case.
Fantastic, Brendan. Thanks so much for walking us through a lot of material in a brief period of time so clearly. I think there are a number of questions here which I think some of which you touched on along the way, but maybe we'll give you a chance to reemphasize some of the points. But so the first one that a few folks had was really around the issue of anticoagulation in patients with valvular heart disease and atrial fibrillation. And so how do we treat a mitral ring or a bioprosthetic mitral valve, for instance, when we're considering anticoagulant decisions for AF?
That's a good question. And I think increasingly, Akshay, and those certainly a mitral ring, I think we would be open to any of the novel anticoagulants. A bioprosthetic valve, it's a little bit more difficult. And I think we could probably, as you look at the studies and their chronology, there was increasing laxity with the willingness to enroll patients like that. And so I think a bioprosthetic valve would probably be considered reasonable in somebody with atrial fibrillation. Certainly if they're on, let's say, a Pixaban or something like that, and then they have an embolic event like a TIA, then I would switch them to warfarin. But I think it's reasonable to consider a novel anticoagulant in somebody with just a bioprosthetic valve, an AFib.
Makes sense. And maybe since it's on your slide here, and it was one of the questions, maybe just to reemphasize, were this patient one with a better EGFR, do you feel comfortable with the use of low molecular weight heparins to bridge mechanical valves?
Yeah, I think that's right. That's a hard question, and I've struggled sometimes with that. If her creatinine clearance were 70 or 60, I think giving the enoxaparin at 1 mg per kg BID would be a totally reasonable option. What I would not do is put her on a DOAC or something like that, right? I mean, you have to use a heparin-based product, I think, in these situations.
So one of the questions that comes with is regarding the frequency with which we do surveillance echoes, for example, in somebody with mitral regurgitation. Could you comment a little bit on that?
Yeah, so I think that my practice has been to do sort of every 9 to 12 months for somebody with severe mitral regurgitation and severe AR as well. If I have the sense that it's accelerating, like I get 2 echoes in a row, and the second one looks worse, and I'm worried that things are changing, then I might do it in 6 months, 6 or 9 months, as opposed to 9 to 12. But there is some clinical judgment there in terms of how frequently to do it. I think the important thing to emphasize, I was always taught that the stenotic lesions, you don't need to do serial echoes. That's probably not totally true, but nonetheless, the regurgitant lesions you often can miss. And so you really should be thinking about when was the last echo. The patient's symptoms haven't changed, but maybe I need to repeat this so that I don't miss something. That's particularly true with the regurgitant lesions. It probably is a little bit true with AS as well, frankly.
One question just speaks to this issue of antibiotic prophylaxis. the question that was asked was specifically about bicuspid aortic valve, but maybe we could just generalize it. Can you just remind us who needs antibiotic prophylaxis?
Yeah, so somebody with bicuspid aortic valve, or for that matter, aortic stenosis or severe mitral regurgitation from myxomatous degeneration, does not need antibiotic prophylaxis, at least according to the guidelines. If that same patient has now had an aortic valve replacement, so they have prosthetic material in there to fix their bicuspid valve, then they would need antibiotic prophylaxis, but only after that procedure implanted the prosthetic material. So this was a change from prior guidelines, really, because we used to people with myxomatous mitral regurgitation would just kind of get antibiotic prophylaxis. We don't do that anymore. At least that's not the guidelines, what the guidelines suggest.
Fantastic. Brendan, thanks so much. I think we're out of time, so we will close there. Wonderful summary of a complex topic, and thanks again for coming.